Okay, good morning, everyone. And good early morning, Professor Jadoul. Now we move to the second part. First, I think welcome to join the hybrid conference, and live and online and the pre-record video. This is the first time in TSN. Okay, next I would like to introduce Professor Jadoul to everyone. Professor Michel Jadoul received his MD degree in 1983 at the University UC Leuven, Brussels, Belgium. And he has served as a chair at the Department of Nephrology of the Clinical University St. Luca since 2003, and is currently a full clinical professor at UC Leuven. Dr. Jadoul's clinical activity focuses on the follow-up of hemodialysis and CKD patients, and his main research interests include beta-2 microglobin amyloidosis, hepatitis C, and other complications in hemodialysis patients, as well as cardiovascular complications after kidney transplant and the various causes of kidney disease. Dr. Jadoul has co-authored over 260 scientific papers, most of them published in major nephrology journal. He is currently serving as a senior editor of NDT, and he is also country co-investigator for the DOPS. In 2008, he received the International Distinguished Medal from the US NKF. He was previously a member of the KDIGO Executive Committee and the ERA EDTA Council. Presently, Dr. Jadoul is a KDIGO Co-Chair. Today, we are very honored to have a talk from him about implementation in Taiwan of the 2018 KDIGO Guideline on hepatitis in CKD. Please, Dr. Jadoul.
Participate in this joint symposium of TSN and KDIGO, and I will speak today about implementing in Taiwan the 2018 KDIGO Guideline on hepatitis C in CKD. Now here are my disclosures, the main one being that, as you certainly know, I've co-chaired the 2018 update of the Hep C in CKD KDIGO Guideline, and I have the privilege to be one of the co-chairs of KDIGO since a year or a little more. Now, the whole story of KDIGO and hepatitis C started some more than 10 years ago when the KDIGO Hep C in CKD guideline was the very first KDIGO guideline. It was well received at that time, but still, as you certainly know, during the last decade, there have been huge changes in the availability of increasingly effective treatments for hepatitis C, as shown on this slide from a recent Lancet paper. So from the 90s, when the efficiency, so the cure of Hep C was only something like 7 to 10% on the left-hand side, you can see that in recent years it has grown to more than 90%, and I will come back to that later. So it was more than time to update that 2008 KDIGO guideline. And so that's why we started having a second work group for the update. Now, I will not mention every single name. This is a slide of a picture of the work group meeting in Portugal, in Lisbon, some time ago. But I would like to stress the key role of my co-chair, Professor Paul Martin from Miami. Now, the names of the work group are on the executive summary from KI, published something like 2 years ago. And both the executive summary shown here and the guideline are freely available on the KDIGO website, open access, and on the KI website. I will also use largely during this presentation this document, which is not yet published but is impressed in KI reports. We had last year a Hong Kong meeting with experts from 8 Southeast Asian countries, And the countries are here. Taiwan was part of that. And we had the privilege of having two colleagues from Taiwan, Dr. Xiu Xing Wang and Dr. Ming Lung Yu, who participated to our discussions, and I will use several of the pieces of that paper that will soon be published. As you can see, this is the last proof of the KI reports paper. Now the guideline discusses the same 5 topics as 10 years ago, although the content has changed dramatically. The chapter 1 discusses detection and evaluation, so let's say diagnosis. Chapter 2, the treatment, dramatic changes. Chapter 3, not that much change, the prevention of Hep C transmission in hemodialysis units, but that does not mean it's unimportant. Chapter 4, the management of Hep C before and after kidney transplantation. And finally, the diagnosis and the management of kidney disease associated with Hep C infection in chapter 5. Now let's move to the first chapter, chapter 1. I would highlight a single recommendation. The work group recommends screening all patients for Hep C infection at the time of initial evaluation of CKD. Now you may have heard that since the guideline was published, for instance in the US, the CDC now recommends universal screening for Hep C, so that recommendation has solid grounds. And the recommendation for patients with CKD is based on a number of arguments. Number 1, Hep C, as you know, we know for decades, may cause membranoproliferative glomerulonephritis. Number 2, there is recent evidence that there is greater prevalence of Hep C in the late CKD stages than in the general population. And in addition, there is a consistent association of Hep C positivity with worse, much worse, liver, kidney and cardiovascular outcomes. And there is evidence that if you treat a Hep C, you improve the outcomes. So the work group considered that the low cost of a single enzyme immunoenzymatic assay for Hep C was little as compared with the potential benefit, and that's why we recommended testing once for a modifiable risk factor. A few examples. Number 1, this is a recent DOPS paper in which we showed that in incident patients, so patients newly started on dialysis from the DOPS 1 to 5 countries, so let's say the large European and the US and Japan countries, you will notice that in those started on dialysis for less than 4 months. And it's well known from the literature that the time required to mount antibodies against Hep C requires several months, especially in dialysis patients. So those started for less than 120 days. If they have antibodies at the start, it means that they have acquired Hep C prior to starting dialysis. And as you can see on this slide, the prevalence is already high, 5.2% in the late 90s, the DOPS 1 phase. And it hardly changed. It decreased a little bit, significantly, but hardly. 4.8% in recent years. That means in 2012 to 2015. So there is good evidence that indeed in CKD stage 5, at least, Hep C is quite prevalent. In addition, there is good evidence that Hep C infection is a systemic disease. And this has been reviewed with Stanislas Paul and Jutla Parlati in a recent Nature Reviews nephrology paper. Hep C, of course, the main target for Hep C virus is the liver, but also the B cells. That's why it may cause B-cell non-Hodgkin lymphoma. And in addition, the hepatitis C virus causes chronic inflammation that may lead to insulin resistance, diabetes mellitus, cardiovascular disease, and may contribute to CKD, in addition, of course, to the membranoproliferative glomerulonephritis, and or potentially to the direct invasion of the kidney by the hepatitis C virus and direct toxicity. Now, I'm happy to say here at this Taiwan Society of Nephrology Symposium, I'm happy to say that Taiwan contributed quite a bit to this evidence. Here are a few examples. The first one is a study from 2013 by Chen and co-workers showing that hepatitis C virus positivity is it independently associated with worse outcomes? And in that case, it's the onset of CKD. So the development of CKD is more frequent if you acquire the Hep C virus than if you don't, as shown quite clearly on that survival curve. In addition, not only Hep C positivity is associated with the onset, but also with the progression to end-stage kidney disease. This is again a study from Taiwan, from Lee and co-workers from 2014, showing again a clear difference as a function of Hep C positivity. And a third study, again from Taiwan, and I've shown these not just today for the TSN Symposium with KDIGO, but I've shown those slides everywhere in the world. Antiviral treatment for Hep C infection is associated with a lower risk of end-stage kidney disease in diabetics. As you can see, the untreated cohort in red has a much worse outcome than the negative, uninfected, or the treated cohort whose curves are very similar. Regarding the other aspects of Chapter 1, I think the single other very important point is that nowadays the assessment of the liver disease can be performed in most cases non-invasively. We use in Europe the FibroScan, so the ultrasonographic assessment of the stiffness of the liver. I think that's true for Taiwan as well, in as much as I know. For the Chapter 2, I will spend some time about this because this is the key change in recent years. The work group recommends an interferon-free regimen, and a number of items will impact on the choice of that so-called DAA, direct-acting antiviral agent regimen. Now, before discussing this, we should keep in mind that the prevalence of the genotypes of the virus is relevant. And I just show here a recent Lancet gastroenterology hepatology paper where the prevalence of the various genotypes of Hep C in Taiwan is mentioned, as you can see, and you certainly know better than me. Genotype 1b is 45%, genotype 2 is something like 40%, and the other genotypes are much less prevalent. That may be important for the choice of some of the DAA regimens. And there are several types, but you should know, and you certainly already know, that those regimens combine a number of agents, at least 2 in every single DAA regimen. Now, here is the polyprotein of the Hep C virus, and there are agents that are active on the NS3, NS4A. These all have in common that the end of the name finishes with previr, like grazoprevir or cimeprevir or teleprevir. Then you have agents that are active on NS5A. Their name always finishes with asvir, like elbasvir, daclatasvir. And a third family is the well-known family of the buvir, like the very first one, the sofosbuvir or the dazabuvir, that act on an NS5B. Now, those 3 families, previr, asvir, buvir, there are several molecules, and the key characteristics may be variable between molecules. Antiviral activity may be present on all genotypes. Some are so-called pangenotypic, and others not. Some are eliminated by the kidney, but others are largely eliminated by the liver. Of course, in late-stage CKD or dialysis, that's very important. The potential to cause drug-drug interactions is highly variable from molecule to molecule, and that's of course associated to the extent to which the molecule is eliminated by the liver or the kidney. And there may be barriers to the viral resistance, and thus there may be the need to add ribavirin, which everybody nowadays wants to avoid, but for some of those regimens there may be the need for some ribavirin. And as I mentioned, at least 2 drugs should be given to any single patient treated with a DAA regimen. Now, what regimen? For those with a GFR above 30, any licensed regimen is fine. You may use what is available in your country, and I understood from the Hong Kong summit that many regimens available elsewhere in the let's say, the modern world or the high-income countries is available in Taiwan as well. For those with a GFR below 30, until 5 years ago, there was very little available. The main reason for that is that sofosbuvir, the backbone of the main DAA regimens, is cleared by the kidney. So until very recently, and at the time of the guideline publication, an eGFR below 30 was off-label use. Now that has changed in the US very recently, not yet in Europe. I'm not aware of the current situation in Taiwan. We may discuss that later. There were some reports, case series, not high-level evidence, that sofosbuvir-based regimens are safe and effective. But there were also some reports that some worsening of CKD progression could not be excluded under sofosbuvir. So sofosbuvir was not an optimal choice. Fortunately, there have been 2 studies, and the first one is shown here. It's the study by David Roth, published in The Lancet in 2015. Grazoprevir plus elbasvir in patients. 3/4 of them were on hemodialysis, and all of them at stage 4, stage 5 CKD, all of them at genotype 1 infection. And the good news for that regimen is that less than 1% of both drugs, grazoprevir and elbasvir, is excreted by the kidney, meaning there is no need to adjust the dosage in CKD. It's a very convenient regimen, a single pill of 100 mg grazoprevir and 50 mg elbasvir. And the primary endpoint is the classical one, so-called SVR, sustained viral response, 12 weeks after stopping the DAAs. Now, the study design of that C-SURFER study was interesting because all patients got the treatment, but half got initially a placebo, and the other half got grazoprevir elbasvir, meaning you had a placebo-controlled initial phase, which makes it possible to assess the tolerance of the drug versus the placebo. And then the group who had initially placebo got the study drug, so all patients were treated. And the results were quite impressive, as shown here. We are here, I will not devote much time to this slide, we are here above the 94-95% success rate. Almost no relapse and almost nobody discontinuing the treatment because of the study drug. Tolerance was indeed better or similar to the placebo. There was a single SAE possibly ascribed to the study drug and one due to placebo, so no difference. And liver function test improved with the study drug versus the placebo. So I was impressed by that paper when reviewing it for The Lancet, and my editorial with my colleague hepatologist Yves Orsmans. The title was, as you can see, Towards Eradication of Hep C virus from Dialysis Units. There has been 2 years later another important trial published in the New England Journal. It's again it's again a multi-center phase 3 study, but in this case open label, no placebo control phase or group. Again, 100 patients, a majority of males, a little bit of everything regarding the Hep C genotypes, all of them at stage 4-5 CKD, and the vast majority was on hemodialysis, and 58% were treatment naive. Here again, the results, within a few weeks, the virus disappears, and that is sustained, so the success rate is 96 to 100%, very impressive. And the tolerance, even though there is no placebo period, the tolerance is very good. You can see here pruritus, fatigue, nausea, 20%, 14%, 12%. As you can see, and as you know, for those having cared for dialysis patients, these are common complaints in dialysis patients. No safety signal and nothing, no reason to be worried. The next question is, who should be treated? We discussed that within the work group, and the conclusion was that in most CKD patients, the potential benefits of treating Hep C outweigh the potential harm. Now, it is true that in some patients with a very short life expectancy, for instance, less than 12 months, it may not be required to treat, but we consider that most patients should be treated. it is important if you treat Hep C to take into account the drug-drug interactions. Now that's manageable because you need only to treat for 12 weeks, so you may need to adapt temporarily or to stop temporarily some other drugs. And the work group recommended to look at the Liverpool University website, where the website is really excellent. And there are tables detailing the potential drug-drug interactions between the Hep C drugs on the one hand and other common drugs in kidney patients and other patients, including antihypertensives and so on. And there is also, for the younger people, an app that you can use on your smartphone, so it's really very convenient. Another important consideration is to test before treating for Hep C. And that's probably even more important in Asia, like in Taiwan, because Hep B is more prevalent in Asia. It decreases with vaccination, but it's still more prevalent than it is in other parts of the Western world. But it's important to test for Hep B, because if you treat for Hep C, within the liver there may be interaction and Hep B may reactivate. So do not forget to test for Hep B before treating Hep C. And the timing of the kidney transplantation, if patients are able to get a Hep C transplant, is important. Now, because the results of transplanting Hep C positive grafts are very good, it's important to determine the timing of the treatment for Hep C in collaboration with the Kidney Transplantation Center. I will come back to that later. There are pros and cons in treating before kidney transplantation. The pros is to clear the Hep C virus prior to the use of immunosuppressive drugs to prevent the worsening of liver disease, to control the MPGN, and to block the impact of Hep C on microinflammation, cardiovascular risk, and so on. There are also cons, because you may not then allow the use of Hep C positive kidneys and thus increase the waiting time for transplantation. So you should find a balance between the pros and cons depending on the profile of the patient and the local situation. Now, after a successful kidney transplantation, you may also treat. Now, if the GFR is good, as shown in that trial published 3 years ago in Annals of Internal Medicine by Massimo Colombo, Cockcroft of 56, the results again are in the 100% range, as you can see here. Almost everywhere 100% success rate, and the tolerance of that regimen was very good. So these key trials were the reason for the recommendation of this table that is in the guideline and discusses on the left-hand side the recommended regimens. And for those with a GFR below 30, you will not be surprised, it's either grazoprevir and Elbasvir, but only for the genotype 1 and 4, or the so-called pangenotypic regimen, the glecaprevir, pibrentasvir for all regimens. For kidney transplant recipients, the backbone of the regimen is the sofosbuvir-based one, even though the glecaprevir, pibrentasvir is effective as well. Now, there may be other regimens that can be used, and these are detailed here. I will not devote more time to these, but it's in the guideline. Now, we discussed what was available in the various Asian countries that participate to the Hong Kong summit, and I'm pleased because I will spare some time that in Taiwan, the line here says no restrictions except referral to a hepatologist, and that's exactly like in my home country, Belgium. But beyond that, you have all drugs available in Europe or the US in Taiwan, so that will simplify that part of the discussion. Regarding the prevention of Hep C transmission inside hemodialysis units, there hasn't been that much news, but I would just want to stress that the guideline didn't change. We recommend not using dedicated dialysis machines for Hep C infected patients, and we suggest not isolating Hep C infected hemodialysis patients. Now, as you can see, this is level 1D, and that one is level 2C. That means that the evidence level is not very high, but the work group still believes now, as the work group thought 10 or 12 years ago, that isolation, any policy of isolation is not required if hygienic precautions are well observed. Now, I'm well aware that in Taiwan and a number of other countries, isolation remains popular. We can discuss that later, but I will not devote more time about that. So hand hygiene and in general hygienic precautions are key, and regular testing the hemodialysis patient, for instance, every 6 months, or if I'm right in Taiwan, every 12 months, is appropriate to make sure that you know if you have new cases. And there is in the guideline 2 tables detailing the key hygienic precautions. Again, it's well known. I will not devote more time, but I'm happy to discuss that as needed later on. Now, where do we stand nowadays regarding the transmission of Hep C inside hemodialysis units? Now, we have taken advantage of the DOPS study to look at that. This is a recent KI paper. And as you can see, from the DOPS 1, the late 90s, the incidence, so the new cases per year, were 3%. It has decreased over the year to something like 1.2%, meaning it has improved a lot, but it remains too much. And that's for the DOPS countries, incidence. I calculated in that DOPS paper that something like 20,000 hemodialysis patients still were contaminated some years ago inside hemodialysis units globally. Now, what about the situation in the Asian regions of the Hong Kong summit? This is not incidence, this is just prevalence, because we are unable to have very recent incidence data. But you are certainly well aware that the situation in Taiwan is still with quite a significant number of Hep C positive patients inside hemodialysis units. Now, that may overestimate the prevalence of viremia, because that study from the registry is based on antibodies. And one reason to think that it may overestimate the actual current problem is that recent study from Taiwan, published in KI as a reply to our DOPS KI paper by Dr. Wang and co-workers, and showing that in a single Taiwanese hemodialysis unit, SVR was obtained in the 15 positive hemodialysis patients with various regimens. I will not detail, so that at the end of that treatment period, it was a Hep C free hemodialysis unit in Taiwan. And I just can encourage you to move in every single Taiwan hemodialysis into that direction. Let's move to chapter 4, which is the management of Hep C infected patients before and after kidney transplantation. I would say 2 things. Number 1, depending on the expected timing of kidney transplantation, you may treat Hep C either before or after. If the waiting time is long, probably best to treat before transplantation. If the waiting time is short, okay, you may treat after transplantation. The second item is that nowadays, with very efficient treatments for Hep C, you may indeed give just a kidney transplant and not a combined liver kidney transplant to patients who need that, even if they have cirrhosis. Of course, the cirrhosis should be well compensated, but recent evidence has shown that if you have a cirrhosis and you start treating when it is compensated, it will not worsen, and it may even improve slowly over the years. So just a kidney transplant may be good enough for those patients. Another hot topic nowadays is the transplantation of Hep C positive kidneys into Hep C positive recipients. Now, at the time of the 2018 KDIGO Guideline, there was data exciting, very promising, but on only 20 patients. Nowadays, 2 years later, there is data on more than 240 patients. So we set the KDIGO work group 2 years ago. As yet, this is an investigational strategy. We did not make a recommendation. That will require an update in the coming months because there is more data now. Last topic of the guideline is the treatment and the management of the Hep C-associated glomerular disease. Now, I summarize here the recommendation. If the kidney disease is mild, you should treat the Hep C infection and see what happens. If there is severe or very severe kidney disease, you should give both antiviral agents and immunosuppressive agents. And I think the key recommendation is that the recent evidence that rituximab is really the top choice And I will just show you one single randomized controlled trial. This is the NIH one. There has been another one from Italy, both published in the same issue of Arthritis and Rheumatism 2012. As you can see in the controls who got placebo, nothing happens. The BVAS, so the activity of the disease, remains unchanged, whereas in the rituximab group, there is a dramatic improvement within weeks or months. And so rituximab is highly effective. So what are the take-home messages of this presentation? I think for me and many other people involved in the battle against Hep C in the CKD dialysis and kidney transplantation world, it's an exciting time because there has been major progress in the treatment of the virus, especially in CKD patients with impressive new evidence. So I would summarize that this is the right time to get rid of the Hep C from the nephrology field, in line with WHO commitment to eliminate viral hepatitis as a public health problem by 2030. Now, I should stress that combining treatment of Hep C and prevention inside hemodialysis is the way to go. And with that, I thank you for your attention. I'll be happy to take questions in the coming minutes. Thank you very much.
Okay, we thank for Professor Jadoul, excellent lecture. And good early morning, Professor Jadoul.
Good morning, yes, no problem.
Okay.
Happy to be with you.
Okay, thank you. And I think there are many questions from online attendance. So first, I think about your transplantation, kidney transplant. One of our members asked you a question about since efficacy of safety of the new DDA treatment for the treatment of hepatitis C is very good. Should we keep the same casein inhibitor levels or lower the casein inhibitor dose or lower the mycophenolate dose or shift to mTOR regimen in the renal transplant with new hepatitis C infection?
So the question is about the use of the immunosuppressive regimens in kidney transplant recipients,
Yes.
in those with hepatitis C. And
Yeah.
I would summarize that I think the key point is that if you give a CNI, be it tacrolimus or cyclosporine, you should take care of the drug-drug interactions, because there may be dramatic drug interactions between at least impaired metabolism of tacrolimus or cyclosporine by a number of antiviral DAA drugs. The other drugs like mTOR inhibitors or mycophenolate mofetil, I mean, there is not much evidence supporting the use or the one or the other. So you may use what you think is best. There has been some not very impressive evidence favoring mycophenolate mofetil versus other drugs. I think it's a very good drug, but no strong preference for one or another. But during the period of DAA regimen, please take care of the drug-drug interaction with CNI like cyclosporine or tacrolimus. I think it's manageable, but then you should monitor the level in blood very frequently to avoid any toxicity or underdosing.
Okay, thanks, Professor Jadoul. Another question is from Nita Lin. According to his question, DA treatment is recommended in HCV and CKD patients since the benefit outweighs the risk. But maybe he or she just wonder if there is any data show about the HBV reactivation rate on HCV and CKD patient receiving DAA treatment. And if CKD stage 4 to 5 patients is also an active HBV and the chronic HCV, what's your suggestion about HBV and HCV treatment priority?
Yeah, I think, as I mentioned, it's important, but to check for that. But the evidence level is not very high. I think the Annals of Internal Medicine paper from the CDC in the US was based on case series. I'm not aware I may have missed that, but I'm not aware of a recent scientific database just about CKD stage 4-5. So that's a topic for a study in Taiwan, if feasible, why not? But I'm not aware of data specifically on that.
I think your topic, everybody very interesting. So, in mind, I bet many questions for you. And the next question is from Dr. Tsai Wenren. According to his question, he asked, does HCV with cryoglobulinemia concomitant lead to low cardiac output heart value in CKD patient? And can treat HCV improve heart value in CKD patient? What's your suggestion?
Well, I've no magic treatment, of course, to propose anything else. My key question would be, I'm not a cardiologist, but still, yeah. I've seen many patients with cryoglobulinemia, and usually these have a lot of salt and water retention because it's a highly proliferative glomerulonephritis. Now, really, my clinical experience and the two small, but still randomized trials are exactly identical. Rituximab is quite impressive. So if you use an immunosuppressive drug, now, yeah. Of course, in someone with severe heart failure, adding another layer of medical complexity with an immunosuppressive drug, you should see the full clinical picture. But at least I would recommend, number one, of course, treating Hep C, and number two, really, if you give an immunosuppressive agent, I think rituximab is the first choice.
Yeah, thank you. I think I need to control time. This is the last question. The question is from Dr. Goldhui Hui. He asked you about, as we know, anti-HCV antibodies may remain positive for a long time or even lifelong in patients after DAA treatment. In the dialysis unit, what's your recommendation of a monitor? This is a previous HCV infected patient after their DAA treatment. What's your recommendation?
Yeah, so the guideline, the KDIGO guideline recommends to monitor every 6 months the antibodies in those who are negative. Now, in those who are positive and get treated, I think it does not make any sense. I would stop monitoring the antibodies. We know they will persist for years, but that's not very clinically relevant. I mean, you should check the classical SVR12, so the viremia level 12 weeks after stopping the DA regimen. If that is achieved and you want to be 100% sure, you might say, I will check again the viremia a year later. But if that remains negative, I think you might stop unless the patient remains on hemodialysis. If the patient remains on hemodialysis and there are other positive patients, viremic within the unit, which may be avoidable with the new drugs, but if there are still other viremic patients, you should test him from time to time for viremia to make sure it does not get reinfected, which is, of course, possible.
Okay, thank you. May I open a question for our live audience? Because we have 2 minutes left. Any question from our audience? Yes? No? Yeah? Okay. We thanks again for Professor Jadoul. Thank you. You joined our joint symposium. And thank you. And thank you, everybody. Okay, we close. I will close the section. Thank you.
Thank you for the invitation.